going to go over neurological conditions and spinal cord injury. And the first condition we're going to talk about is Parkinson's disease, which is due to low dopamine in the brain. Let's just say it like that. Keep it super easy, okay? So it's characterized by tremors, and these are resting tremors. So pill rolling is the common one that's described. Slow movement, otherwise known as bradykinesia. Stiffness, otherwise known as rigidity, muscle rigidity. Balance problems, so they're going to be at a risk for falls, especially because they have a stooped posture. They can become orthostatic. They can have extreme fatigue and a slow GI tract. So constipation is going to be a problem, and so isn't urinary retention. Some other symptoms that they can have that don't have anything to do with motor symptoms include depression and anxiety. They can lose their sense of smell, and that's called anosmia. And that can happen 20 years before symptoms even occur. They could be drooling due to dysphagia, difficulty swallowing, and I mentioned memory changes, but Parkinson's disease is not always characterized, or it doesn't always present with dementia, okay? So that may happen later. So the risk factors, it's genetic, usually occurs in men, or I should say the incidence is higher in men's, and it could be due to chemicals, pesticides, TBIs, like people that have repetitive sports injuries. Like, I don't know if you remember Muhammad Ali, the boxer, he ended up developing Parkinson's disease. Okay, so again, the symptoms can be characterized or remembered by the mnemonic Be Smart. So bending forward, shuffling gait, mask-like face, akinesia or bradykinesia, meaning lack of movement or slow movement, rigidity, and tremor. So the triad of symptoms is the resting tremor, bradykinesia, and rigidity. They can also have symptoms like, I talked about this, difficulty swallowing, dysphagia, diaphoresis, flushing, and orthostatic hypotension. So what we want to always do is keep people safe. So people with Parkinson's are at risk for aspiration. I was really pleased in class when you all did great on aspiration precautions. They're going to be at risk for pneumonia. So also remember, after feeding, you need to listen to the lung sounds to make sure they, don't develop adventitious lung sounds, because that could be a sign of pneumonia. And also check for a temp, because that could be an early sign of pneumonia as well. Risk for falls. You guys did great on fall precautions in class. In wandering management, that early on, that's going to be a problem. The nursing care is in your textbook. We talked about it during a case study. I always recommend that when we do case studies, you need to sit down and read all those rationales within 24 hours. That way you won't forget what we were discussing during the case studies. Really important for you to be able to apply the information. All right, the medications typically prescribed can be remembered by the mnemonic SALAD. Celgene, which is a Mayo inhibitor. So we're going to talk about the foods they need to avoid. And I find that you are well versed in the foods to avoid by the time you get to this class. Anticholinergics, which can cause a dry mouth. The levodopa and the carbidopa. Monitor for wearing off, meaning the symptoms are coming back. And then you might have to call the provider and adjust the medications. Amantadine, you don't want to give that at night. It's also used for attention deficit disorder. Dopamine receptor agonist, the most popular one is bromocriptine, and that can cause CSF leakage. So if you have any clear drainage coming out of the nose or the ears, check for halo. Okay, Mayo inhibitors. You can remember the foods, the tyramine foods. Remember, it is aged cheese and hard cheese. So just kind of spend some time reminding yourself which type of foods to avoid. Peripheral neuropathy. So peripheral neuropathy could occur due to a lot of the conditions we are talking about this unit. Okay, so like post-stroke, um, post-spinal cord injury. So the main thing with that is keeping people safe, because when somebody has peripheral neuropathy, they can't feel and they might not be able to move. Okay, so that's important to know. So like, for example, checking the water temperature, not with their feet, right, but checking with the thermometer before getting in a bathtub. Now, another thing that can happen with stroke, with spinal cord injury, is that people can develop foot drop. So they need to have these boots on to hopefully prevent or to help manage foot drop, because that, if they are able to ambulate, that's going to be a problem. And then people with contractures are going to need certain braces as well. Okay. And then what we used to do for people that had like spinal cord injury, or they had a stroke and they had foot drop, we would just put basketball sneakers. We had a special pair that was only for bed. We used to put those on them to prevent or to treat. So Guillain-Barré syndrome. Okay, so this syndrome, I'll tell you what the questions usually are. It occurs after a respiratory or GI virus. So somebody has some type of virus. Young people usually, but it's an autoimmune reaction to the virus, and it affects the spinal cord nerves and the cranial nerves. So it's characterized by numbness and tingling of the feet and hands, pain in the shoulders, thighs, and pelvis, but the most important thing is ascending paralysis. In other words, they get weak and ataxic, and they have weakness starting in their feet, and it travels up. And what you're worried about is that it's going to travel up to their lungs, to the lung area, right? The ascending paralysis, and they're not going to be able to breathe. So when the paralysis gets to about the hip level, you're going to start thinking this patient needs to be prophylactically intubated. The outcomes are good for Guillain-Barré syndrome. It's just that they need to be intubated, and then they usually have a full recovery. Okay, multiple sclerosis. This is a progressive, irreversible condition. What happens is the myelin sheath is destroyed on the nerve, so the nerve conduction is going to be slower. It affects the optic nerve. They often present with blind spots and diplopia, so that's double vision. It could attack the cerebrum, the brainstem, the cerebellum, so they have ataxic walking, and the spinal cord. 4 different types, don't memorize them. MS is characterized by remission and exacerbation. So you're looking for new findings, loss of function, and hopefully that they will have remission, periods of remission. The triggers include cold climates, hot showers and baths, viruses. So that's why we tell people to stay away from people with infections in crowds. And you did very well when we did the case study. Fatigue, pregnancy, and physical injury can all trigger an exacerbation. Risk factors: it usually occurs in women with a first-degree relative that has MS. The signs and symptoms can be easily remembered by the mnemonic demyelination. So diplopia, I talked about. Eye movement. So they have involuntary eye movements, which is called nystagmus. They'll have motor weakness and muscle spasticity. Okay, so spastic muscles. They could have an elevated temperature. It's an autoimmune condition. And they can have something called Leitmeit's phenomenon. And the way I remember what this refers to, it's an electric shock. They feel an electric shock go through their body. So I remember that because it has an E and an S for electric shock. That's how I remember that. They are going to have pain. They could have ataxia, so that is uncoordinated movement. They could be talking slurred, and I think I mentioned before when I was in nursing school, I did private duty CNA work, and I cared for some people with MS. And one of the signs, one of the patients shared with me is that the people at work thought they were drunk when the symptoms first started happening because they had slurred speech, and also they were ataxic. So that can happen. Impotence and intentional tremor. Intentional tremor means when they're trying to do something like grab a coffee cup, right? They'll have a tremor. Overactive bladder or spastic bladder. We'll get into that later. And numbness, okay? Overwhelming fatigue is classic too, just like any autoimmune disorder. And I think I mentioned dysphagia before, so trouble swallowing. They can also get intense muscle spasms in their intercostal muscles, and it causes pain around their chest. They feel like a big blood pressure cuff is like around their chest and squeezing. It's called the MS hug. When I was in nursing school, we called this girdling. So the name has changed. So it's characterized by burning and dull or tingling pain around the chest. Okay. People with multiple sclerosis, of course, there's different degrees, right? Not everybody's going to have the same signs and symptoms, but they can get pyelonephritis, which is kidney infections due to repeated UTIs. So they would have like a fever too with that flank pain. All right. With diagnostic tests, there's no one thing that's going to diagnose MS. So it's diagnosed by putting everything together. MRI is going to show plaques of the brain and spine. They're going to have increased protein in their CSF. They would do an LP, increased WBCs, and increased lymphocytes. Okay, take action. You want to tell them to alternate periods of rest with periods of activity because they do have activity intolerance. You want to know about their coping mechanisms. Do they have good support? Visual acuity. How is their acuity? All right. Because if they're having blind spots, they're not going to be able to drive. MS interventions encourage fluids to flush out the bladder. Intermittent self-catheterization, they'll have to be taught that, and that's going to be done every 3 to 6 hours if they need it. Credet's method means bladder tapping, like pressing on the bladder if they have a full bladder to try to get the urine out because their bladder is spastic. If they're on avoiding schedule, remember it's frequent, every 1.5 to 2 hours they have to remember to void. And then you can offer an eye patch for the double vision. And if they have blind spots, just like when we talked about stroke, they need to scan their environment. And you would put things in their field of vision. And stay away from crowds because we don't want them getting infections because they're most likely taking disease-modifying therapies. So immune drugs that help decrease inflammation in the body. Okay, baclofen is an antispasmodic, so muscle relaxer, and it can cause drowsiness and dizziness. So you would tell them not to drive or operate like power tools or heavy machinery until they knew what the outcome or the effect is of the baclofen on them. It could cause nausea, and you don't ever stop it abruptly. Okay, spinal cord injuries. Lots of different ways people can get spinal cord injuries from falls, motor vehicle accidents, diving accidents. Risk factors. Males 16 to 30 because they're so impulsive and they think they're invisible. Okay? Falls in older adults. So older adults, as you age, your sight isn't as good, especially in the dark. and your strength declines. Okay, they also have chronic hypertension and have taking a lot of meds, so polypharmacy, and they can become orthostatic. So there's a lot of reasons that older adults can get a spinal cord injury or even a TBI. Anytime somebody's at risk for a spinal cord injury, they're also at risk for a head injury. And if they have a head injury, they're at risk for a spinal cord injury. So you always check both at the same time when you're doing the assessment. Prevention, lock your guns, wear seat belts. And you may think that's weird, but like I remember I lived in Massachusetts in nursing school, and when I was a junior, there was a law passed that everybody had to wear seatbelts. We didn't wear seatbelts back in the day. It was like a big deal to get people to wear seatbelts. And they were like, the police were doing like random stops. They would stop you, and if you weren't wearing a seatbelt, you get a ticket. But how far we've come is great, but people need to be reminded to wear their seatbelts all the time. Don't don't drive and use your phone. Make sure children are in car seats. Fall precautions, you guys did great with that. Trampoline should be at ground level. Water safety, so no diving if you don't know what the depth of the water is. And people should wear helmets when indicated. Okay, so there's all different kinds of variations of a spinal cord injury. It could be complete, which is sometimes referred to as a transected spinal cord injury. And if you look at this picture and you see the complete, you see where the redness is. So the redness indicates a loss of sensation and movement below the level of the injury. And that's for complete. So it's total. No sensation or movement below the level of the injury. Whereas the incomplete, it can be varying degrees. Okay. This picture is just to show you the different levels of injury. So somebody with a C4 is going to have tetraplegia, which is quadriplegia. Cervical spine 3, 4, 5, keep me alive. That's where the nerves that innervate your respiratory system are. So that's why with the cervical injury, you're always worried about respiratory problems. Okay, and then T6 injury is considered paraplegia. Okay, so that's just describing what I just said. Okay, and T6 and above are going to be prone to neurogenic shock and autonomic dysreflexia. We'll talk about that in a little bit. Okay, when somebody has trauma, the primary survey calls for the ABCDE framework. And we talked about this in class when we did the spinal cord injury case study. So A is for airway and cervical spine. So when people have trauma, they usually come to the ED, they're brought to the ED by the EMTs, and they have a hard cervical collar on until it's ruled out that they don't have a fracture of their cervical spine by the provider. Breathing, you want to make sure you take your stethoscope and that you can hear breathing going on, okay? When I worked in the PACU, that's one of the first things we did when they came from the OR is we took our stethoscopes and truly counted the respirations while listening to lung sounds. That's because the chest can rise and fall without air going through. So that's why you do that. Circulation refers to feeling the pulses, making sure they're +2. Also checking the blood pressure. And at this stage, you would insert 2 large bore IVs if somebody came in with trauma. And that's to give a lot of fluids to keep the blood pressure up. D is for disability or neurological assessment. So typically the Glasgow Coma Scale can be used. There can be other things too, like if your patient is talking to you and they're alert, their airway, breathing is fine, right? E is exposure, and that's when they strip them and flip them when they come into the ED. And that's, you're doing a total body scan, front, log roll, and look at the back real quick. But you also want to make sure that the patient is kept warm, okay? You don't want them getting hypothermic. All right, this is a picture of a hard collar. And I mentioned if somebody has spinal cord injury, you're going to look for TBI. And we always log roll patients with a hard collar on, right? Spinal shock is the temporary loss of motor, sensory, and the reflexes below the level of the injury. Okay, so it can resolve in a few weeks or can resolve in 48 hours, but patients get that after having a spinal cord injury. Okay, so they're going to have flaccid paralysis. With neurogenic shock, okay, that occurs in injuries of T6 and above because they lose the sympathetic nervous system innervation, T6 and above. They're going to have massive peripheral vasodilation, which puts them at increased risk for DVT. A lot of patients with spinal cord injury die from pulmonary embolism, so you need to be monitoring their calves because they're not going to be able to feel pain. The neurogenic shock is the only shock that presents with bradycardia. Okay? They'll have hypotension, orthostatic hypotension, and this can last for several weeks. Okay? So neurogenic shock, remember the bradycardia. And they can be hypothermic too. People with spinal cord injury cannot stand like extremes in temperature. They can't regulate their temperature. So you always want to make sure the room is warm, that they're covered up, so that they don't get hypothermic. So high risk for DVT, especially in the first 72 hours, so monitor for that. They need to be on the low molecular weight heparin, so enoxaparin usually, within 72 hours, and they need to be on it for a long time, like 8 weeks. So you'll have to teach the family how to monitor their calves, but also how to give the medication if needed. All right, so atelectasis and pneumonia are going to be problems. They could aspirate, so you already know aspiration precautions. Give mouth care frequently to prevent aspiration. Cough and deep breathing exercises need to be done every 2 hours. Oral and tracheal suctioning, PRN. All right, we never suction on a schedule. The other thing with suctioning is if they had a head injury, that can also increase intracranial pressure. So we only suction when absolutely necessary. And you would know by listening to the lungs, and they would have like bronchi. So you would have to suction. And you want to strengthen their chest muscles. They should be working on that in PT. Cough assist. This may be needed for anybody with tetraplegia. So you would assist in their coughing, and you need to do respiratory assessments Q4. The GI complications, okay. Paralytic ileus, so if they don't have bowel sounds, and even when they first come in, they may get an NG tube. That's important to know because you want to prevent aspiration. Stress ulcers occur in people that have massive trauma, okay? People that are intubated are going to be at risk for stress ulcers, but people with spinal cord injury, since it's such a major injury, are going to be at risk for stress ulcers too. And I'm talking about, when I talk about stress ulcers, I mean GI ulcers. So they're going to need prophylaxis for that. So like a PPI or an H2 antagonist. They'll need stool softeners. They will need digital stimulation. If they have upper motor neuron lesions, are going to be spastic tone bladder, and lower motor neuron lesions are going to be flaccid tone. Okay, so with upper motor neuron lesions, okay, so L2 and above, spastic muscle tone, so you could pull or tug on their pubic hair, just try to get them to urinate. But they're going to need clean, once they go home, the procedure for intermittent catheterization becomes a clean procedure. Okay. Lower motor neuron lesions have flaccid muscle tone, so you would do Creday's method, which is pressing on the bladder, and they may also need intermittent catheterization. Okay, autonomic dysreflexia. I talked about this in class. It was in our case study. It is it occurs in people with T6 injuries and above. okay? And it's triggered by stimuli below T6, below the level of the injury. All right, so what's going to happen is because of these sensory issues, right? So the noxious stimuli below the level of the injury could be due to having sex, full bowel, full bladder, draft or fan, a pressure injury, tight clothing, wrinkle in the sheet. Okay, so those are the triggers. The patient is going to present with a severe throbbing headache, high BP, diaphoresis above the level of the injury, cool, clammy skin below the level of the injury, flush face, piloerection, which means goosebumps, and nasal congestion. Okay, how I remember flushed face is above the level of the injury and pale skin is below the level of the injury. Okay, because there's a male appendage that begins with the letter P that is below the level of the injury. That's how I remember that they're going to be pale below the level of the injury. So again, the triggers include bladder, bowels, boils. So that means like sores. Bones and babies, okay, and back passage. Take action. The first thing you're going to do if you suspect it is elevate the head of the bed. You want to find the cause, prevent the causes, and take care of the causes. To prevent pressure injury, turn Q2 in bed. Wheelchair, and you might have a bed that you only have to turn Q4. Those are like the best. Wheelchair shift every 15 minutes if possible. Now, this Halo device is highly tested. It's an external fixator that stabilizes and immobilizes the cervical spine. So not everybody that fractures their vertebrae ends up with a spinal cord injury. But what you're trying to prevent is further damage and a spinal cord injury. So that's why they put this immobilizer on. It comes with a little wrench. So you're going to tape that to the vest in case they need CPR. There are 2 anterior pins. You can see in the head here, 1, 2, and 2 posterior. They need pin care daily. Monitor for infection. You never, loosen, tighten the pins. Okay, that's a physician thing. 1 finger should fit under the vest. They need their food cut up small because you don't want them to choke. Increase fiber and fluids in the diet because they're not going to have as much movement as they did previously. They're going to have balance problems, so they're going to be on fall precautions. No driving, and it's okay to have sex. And here's just a little diagram of the spinal cord and what the nerves innervate.